Hello, everybody. My name is Saanvi Kulkarni, and I'm excited to present to you my research on the considerations for anesthesia in the setting of diabetes. Before doing this research, I didn't have much knowledge about either anesthesia or diabetes. However, as I grew older, I met people that had been diagnosed with type 1 diabetes and my father, who was diagnosed with type 2 diabetes. On August 21st of 2023, my father had to get a surgical procedure done. Questions ran through my head about how a surgery for him, a diabetic, would be different than if it was done on a healthy person. After doing my research, I was able to answer the following questions. How different anesthetics affect the body, how different medications for diabetes have different preoperative rules, why doctors must account for diabetes when going into surgery, and how diabetes and anesthesia interact in the surgical setting. To begin my presentation, I'm going to give you some background information and research I did before drawing clear connections between anesthesia and diabetes. My first topic was anesthesia, specifically general anesthesia. The primary goal of general anesthesia is to make a patient unconscious and unable to feel the pain of surgery. General anesthesia is most commonly used for major operations, such as heart surgeries or joint replacement surgeries. Before anesthesia is administered, anesthesiologists, or doctors of anesthesia, must explain lifestyle changes such as stopping a medication or fasting days prior to surgery. This is to ensure that food does not enter the lungs and no complications arise from medications interacting with anesthesia. Anesthesia also relaxes the body's muscles, so anesthesiologists will assist in monitoring the body's functions. The anesthetic medications work by blocking signaling in the brain. However, these interactions have an effect on diabetes and the medications that come with diabetes. I further studied diabetes to complete my research paper as well. It is an endocrine disease that involves either a lack of insulin or a resistance to insulin. Diabetes affects about 1 out of 10 adults in the United States. That means that about 38 million people have diabetes. While type 1 diabetes is an autoimmune disorder, which involves low insulin levels, type 2 diabetes is a result of lifestyle choices, such as being obese. Type 2 diabetes can be cured by adjusting your lifestyle to incorporate healthier foods and exercise, but type 1 diabetes has no cure. Thus, each has their own pharmacology, which requires adjustment prior to surgery. For the sake of time, I will be talking about two medications, metformin and insulin. Metformin is one of the most widely used glucose-lowering agents in the United States. One of the major concerns when going into anesthesia with metformin is lactic acidosis. Lactic acidosis occurs when lactate builds up in the blood and the body's pH becomes too acidic. This is mainly of concern for people with chronic kidney disease, heart failure, or chronic liver disease. That is why for major surgeries, metformin should be stopped the day before surgery. The medication should be resumed once oral intake is restored and the kidneys are stabilized. Insulin, on the other hand, is most commonly used to treat type 1 diabetes, but it can be used in type 2 diabetes treatment as well. The major cause for concern for insulin is hypoglycemia, or low blood sugar. This could be a risk during surgery, so it is advised that long-acting insulins be discontinued or have a dose adjustment 1 to 2 days before surgery. Intermediate insulin can be used up until the morning of the surgery with dose adjustments, and short-acting insulin should be held off on the day of surgery. Two of the major concerns when going into surgery with a diabetic patient are the extremes of glycemia. While there is no concrete agreement about a specific range for glucose levels in diabetics, during surgery, there is a general target of maintaining blood glucose levels below 180 milligrams per deciliter. If the goal is too aggressive, hypoglycemia may occur, and even though both hyperglycemia, high blood sugar, and hypoglycemia, low blood sugar, are both of concern in the surgical setting, hypoglycemia can be much more fatal than hyperglycemia. Low blood sugar is also very difficult to recognize during surgery due to hemodynamic variability and the anesthetic agents altering the blood glucose levels. When hypoglycemia does present itself in the surgical setting, anesthesiologists will administer an IV dextrose solution more commonly known as sugar water, into the bloodstream. The percent of dextrose is altered depending on the severity of the hypoglycemia. If a patient is conscious, oral carbohydrates are given, such as honey or fruit juice. Measures are taken in the operating room to avoid these complications, such as the administration of IV insulin, glucose, potassium, and other fluids. In combination, these fluids help to stabilize blood sugar of a patient. IV insulin allows doctors to put insulin directly through to the bloodstream, which controls blood sugar levels and prevents them from dropping or raising too high. It is usually given in combination with glucose and potassium in a GIK solution. This is an efficient, safe, and effective way to stabilize blood sugar levels. The dosing is dependent on the patient and the type of diabetes that they have. Along with using these fluids and monitoring blood sugar every hour, patients are not likely to have complications during surgery. After surgery concludes, IV insulin may be given for a short time to wean off a patient. It is important to note that intraoperative glucose management affects postoperative outcomes. Oftentimes, when a patient has hyperglycemia during surgery, they tend to have longer hospital stays than those that had stabilized blood sugar levels. However, this is also a very general notion for all diabetics, as they tend to heal slower than non-diabetics. Additionally, patients with diabetes may be more prone to infection and cholesterol buildup. Overall, they tend to take more time to recover than a non-diabetic. Medications for diabetes may be resumed once oral intake is established and renal function is stable. Diabetes mellitus is a growing population in the United States. There are likely to be a multitude of patients in the operating room with diabetes. Therefore, it is imperative that medical professionals understand the interactions between diabetes medications and anesthesia, as well as how to care for diabetic patients intraoperatively. Furthermore, it is important for diabetic patients to understand what their surgery may look like and how their preoperative procedure and postoperative outcome may be different from their non-diabetic peers. This endocrine disease does not only affect lifestyles, but it also affects the surgical procedures, and it's important to understand the mechanism for each of these effects. Thank you so much for listening, and I hope you learned something from this presentation.